a.m. Thank you all for joining us. morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor computer audio, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as a part of registration remains confidential. Statements of credit will be posted 30 business days after the evaluation closes for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close midnight Monday, December 12th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers when you registered for this webinar. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please remember, WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Our presenter today, Emily Clark, is the lead therapist for Greenhouse Outpatient Treatment Center and runs the Personalized and Therapeutic Healing Program in Arlington, Texas. PATH assists individuals with co-occurring disorder gain tools and skills for a safe and healthy recovery. Ms. Clark specializes in healing from trauma and PTSD, seeking safety, substance use, mental health treatment, psychiatric medication management, cognitive behavioral therapy, dialectic behavioral therapy, and Jugen analytical therapy. And now I would like to welcome our presenter, Ms. Emily Clark. I'll turn the presentation over to you.
Thank you so very much, Ms. Rebecca, and thank you, FADA, for this opportunity to present to all of y'all today. Our presentation is going to be over identifying and treating multiple behavioral health conditions. As Ms. Rebecca so kindly already introduced me, I do specialize in substance use and addiction and mental health. This presentation, just so we are all aware as we're going through it, is from the point of view of addiction and substance use, specifically polysubstance use. So we are going to be learning a little bit further within addiction and how co-occurring disorders fit into the behavioral health treatment model. So without further ado, we'll go ahead and get started. So a little bit about me. I do live in Texas. I was born here, raised here, continue to live here, and I am employed by American Addiction Centers and am the lead therapist of Greenhouse Outpatient Treatment Center in Arlington, Texas. I received my bachelor's in psychology at University of Texas at Tyler from August 2014 to December 2016. I've received my master's about 2-3 years later in social work with a concentration in mental health and substance use from University of Texas in Arlington. And I have worked in mental health and substance use since 2015. I have worked as a behavioral health technician, a patient advocate, and now as a therapist. So thank you all for joining us today, and thank you for being a part of this presentation. As we go through the presentation, we are going to have a lot of opportunity to interact. Of course, like Ms. Rebecca said, a lot of your interaction is going to be through the chat. Well, all of your interaction is going to be through the chat. I am going to be asking some questions throughout the presentation to just offer a little bit of activity for y'all. And there is also some trivia that we're going to do throughout the presentation, and then halfway between the presentation we will stop for questions, and of course at the end of the presentation we will stop for questions. Our objectives that we are focusing on today, so we are going to learn to identify specific criteria for multiple mental health and substance use disorders. We're going to gain an understanding of how mental health influences polysubstance use and cross addiction. And we're going to discuss multiple treatment tools and options for various fields of behavioral health care service providers. Our modules that are going to be included in today's presentation, our intro, which is going to go over what polysubstance use is and kind of going through the statistics of that and just kind of allowing you to get a feel for where the presentation is going to take you. We're going to work through identifying what an addiction looks like. We are going to look at co-occurring disorders and look how substance use and mental health work together and how we can treat both of those together. We're going to look at treatment and recovery as a whole. We're also going to look at that final stage of recovery that focuses on the maintenance of recovery, what we do in the sense of a relapse, and how we continue to influence and encourage safety. We'll also go through different resources and, of course, the references for this presentation. Alrighty, so we're going to go ahead and get started. So one of the largest threats to recovery and healing are polysubstance use and cross addiction. So within this intro, we will define polysubstance use. We're going to discover pertinent statistics and discuss those. And we're going to discuss prevalent substances that all behavioral healthcare professionals need to understand the trends and the dangers of, so that we can better provide services to our populations. So defining polysubstance use. So the use of more than one drug, that is what is known as polysubstance use. This can be when 2 or more drugs are taken together within a short period of time, either intentionally or unintentionally. And why it's important for us to, as healthcare providers, to be familiar with this: the majority of individuals suffering from addiction and mental health do experience polysubstance use, and it affects individuals a great deal within their perspective of recovery. Polysubstance use is incredibly prevalent. More than half of individuals who are hospitalized and have a substance use disorder use more than one substance. If you look at the graphs there on the right side of this slide, we can see that in the graphs that the individuals who limited or abstained from their drug of choice, they increased the use of other substances that they did not deem their drug of choice. In mental health and substance use treatment, we often hear individuals bargaining with their recovery. Oh, if I stop drinking, I can still smoke marijuana. If I stay compliant on my medication and go to therapy, I should be able to have a drink and relax every once in a while. It's important that these thought patterns, especially within the treatment of recovery, are addressed, as well as the harmful effects of polysubstance use. And we're going to get into definitely some CBT, DBT, and other forms of therapy later on in the presentation. It is important that as behavioral health providers, we are understanding of the dangers of polysubstance use. So we're going to go over those very, very quickly. When we mix stimulants, it's important that we understand that stimulants, also known as uppers, can increase your heart rate, your blood pressure. It leads to dangerous levels and increases your risk of several serious health problems, brain injury, liver damage, heart attack, stroke. Signs of use or overdose that may occur when mixing stimulants. We do have trouble breathing or fast breathing, increased body temperature, nausea or vomiting, chest pain, and seizures or tremors. It's important to note that examples of stimulants would be ecstasy, also known as MDMA, cocaine, methamphetamine, and amphetamines, whether they are prescribed or are synthetically made. When we are mixing depressants, this is what this looks like, and this can become extremely dangerous. Examples of depressants would be opioids, whether heroin, morphine, oxycodone, fentanyl, and benzodiazepines, and also alcohol. So depressants, also known as downers, they slow your nervous system down, they slow your breathing down, and combining depressants can directly affect your breathing and your brain function. This can lead to overdose, damage in the brain, and even death. Signs of a use or overdose when mixing depressants would be slow breathing, a weak pulse, altered mental status, or even passing out. And specifically within opioids, we are going to go over overdose prevention within the end of this presentation. Mixing stimulants and depressants, this can be extremely, extremely dangerous because when we mix a depressant with a stimulant, we almost confuse our body into thinking, oh, I'm not inebriated anymore, or I'm not intoxicated anymore because now I have that stimulant on board. Well, it doesn't do that. It actually creates further damage to your body and further inhibition. So it's incredibly important that we talk our individuals that we are treating. I cannot tell you how many individuals that I have treated that think, oh, if I utilize a substance like cocaine, I'm not drunk anymore. So it's very important that we share this education and information with them. And then also, of course, drinking alcohol while using other substances. So drinking alcohol while using drugs is not safe. Alcohol is a depressant with similar effects to other downers. Mixing alcohol with other drugs can increase your risk of overdose and serious damage to your brain, heart, and other organs. It's important to note up at the top of the slide, in 2019, it was recorded that almost half of all drug overdoses involved multiple substances at once. The use of more than one substance at a time continues to increase as a common pattern of substance use. It's quite often the individuals that we see come in for addiction and substance use treatment are using more than one substance, either at that time currently of treatment or in the past. So it's definitely important to go over all substances that an individual may be abusing. All right. So as providers, we also need to familiarize ourselves with the most commonly abused substances as well as their trends. The most common substance within our nation is alcohol. Alcohol is by far the most commonly abused substance. 10.2% of all Americans struggle with an alcohol use disorder, far more than any other substance. More than half of all Americans, that's about 166 million, identified drinking within the last year. The current numbers of people in the US who have reported illicit substance use within the last year, within marijuana, 49.6 million. Marijuana is still considered illicit within the federal laws. Prescription painkillers, and this is accounting for people who use them without a prescription, 9.3 million. Hallucinogens, that accounts for mushrooms, LSD, 7.1 million, tranquilizers, 6.2 million, cocaine, 5.1 million, prescription stimulants, again, without a prescription, 5.1 million. This accounts for Ritalin, Vyvanse, Adderall. Methamphetamines, 2.6 million, ecstasy, 2.6 million, inhalants, 2.4 million, heroin, a little less than 1 million, and crack cocaine, a little less than 1 million as well. All right. We as treatment providers need to further understand what addiction is, what it looks like, and what it feels like from the point of view of the population that we are going to be serving, and how it impacts an individual's life. So this video is going to allow us, coming up next, to allow us to understand what addiction looks like. I really, really love this video, and while Rebecca is queuing it up, I'm going to offer y'all a little bit of an introduction. This is a perfect video to not only show your clients and their family members, this is a perfect video to show to children. This is a perfect video to help people going through junior high, high school, to understand what addiction is, what it looks like, and how it feels. I do want to have a little bit of discussion after this video to see what you gained from it. So as you're watching this video, if you can start utilizing the chat function and just let me know what did the video bring up for you? What did you notice in the video? And what did you think about the video? All right, but we'll go ahead and play it as soon as Rebecca is ready.
We're having a couple little difficulties at the moment. We're trying to load the video, but we're having some problems with WebEx on Rebecca's end. Let's give it 1 second. Let's see if we can get it up.
Sure, absolutely. While we are waiting for Rebecca to load this video, does anybody have any questions that they would like to put in the chat as of now?
Emily, we're still having some issues. We're going to try and make myself the host and see if I can play the video for you.
Sure, absolutely. While we are working on the video, I do see some questions coming through. I do see one comment, no questions, but the statistics are alarming. Absolutely. They are very alarming. And what is even more alarming is that they are continuing to increase every single year. The trends are continuing to go up, and polysubstance use as a whole is continuing to increase at a younger age, year by year by year, with more and more substances being available. I see another comment. I am encountering more and more members having issues. Oh, sorry. I am encountering more and more members having issues with kratom. Do you have anything on that? Oh my goodness. So kratom is extremely popular right now. I am unfamiliar with Florida's laws, but it is actually legal here in Texas. Kratom is something that we definitely screen for when we do random drug screens at my facility. Kratom is being, a controversial substance because people are like, it's legal, it's not addictive. Well, the fact of the matter is that it is incredibly addictive. It works as basically a baby synthetic opioid, and it can be extremely, extremely addictive. And it also leads into further, increasing tolerance, causing other withdrawals that leads people to more intense and severe opioids, such as prescription opioids, synthetic opioids, such as heroin, and even into fentanyl.
And Emily, I have the video pulled up, so whenever you're ready, I can go ahead and play it for you.
Perfect. Let's go ahead and do that.
All right.
Thank you so very much. So yeah, I'm seeing a lot of reactions in the chat. Some of y'all have seen this video before. I love that. But definitely I'm seeing a lot of noting of initial euphoria as the tolerance and then the subsequent addiction and the impact on someone's life. It becomes more painful, absolutely. Another person said that progression hits home. Each drop is harder and the up is shorter. The amount taken increase, but the duration of the euphoria feeling decreases combined with stronger crashes. Absolutely. Oh, I love that someone noticed this. The overall atmosphere surrounding this character in the video gets darker as the person goes through this, what is perceived to be an addiction. Coming down becomes more and more difficult. The health of the individual seems to be deteriorating. Absolutely. Deterioration again. Oh, I love your interpretation of this. Someone put depression now ensues due to the resistance and negative effects of the cycle of dependence. Absolutely. It's very clear that the effects tend to be less effective each time, and the time in between use shortens more and more. Absolutely. So we can see that through this video that the addiction becomes extremely strong. He is running to the next golden nugget. And we see as he continues to move forward, he gets heavier. We look at that as deterioration, depression. The highs, continue to get less and less high. And that's what we would look at as tolerance. The very last scene of this video really hits home to me, because that's where I see a lot of my individuals coming in for treatment, is that challenge in their life that I can't do this anymore, where our character looks at that golden nugget at the very end and he wants to take it, but at the same time he doesn't want to. And that's where a lot of our individuals meet us at, and that's where we have to meet them at. And that's what we would call that challenge to change. Some people look at it as a rock bottom. Other people look at it as, I just can't do this anymore. So I appreciate all of y'all's responses to this video. Thank y'all very much. And like I said, this video is an incredible video to show to adult clients, and a really good video to explain to children what addiction is. So thank y'all very much for your reactions. All right, so moving on forward. So we definitely need to be aware of what our criteria for substance use is, because so many individuals who abuse or misuse substance are impacted by the below criteria, but are not diagnosed. And some of our individuals aren't aware that a lot of this criteria below is what makes up an addiction or a substance use disorder. 15.4% of all Americans struggle with a substance use disorder each year. This equates to approximately 39 million people. Excuse me. This does not account for individuals who use or abuse substances, only those who have been thoroughly diagnosed with a substance use disorder. So there is a lot of data not included within that number or that percentage. So some of our diagnostic criteria that we need to be aware of, the first and foremost is increasing tolerance. This is the alteration of the body's responsiveness to alcohol or a drug, such as higher doses are required to produce the same effect achieved during that initial use, what we just saw in that video. Withdrawal symptoms. So a set of symptoms that are experienced when discontinuing a use of substance to which a person has become dependent or addicted. We need to be familiar with, when we're treating individuals, their drug of choice, and we need to be familiar and educate our individuals in treatment as to what specific withdrawal symptoms or post-acute withdrawal symptoms that they might be experiencing, because each substance is unique. Using in larger amounts for longer than intended. Wanting to cut down or stop using, but not managing to. we treat so many individuals that come in like, I didn't intend to keep using past Sunday night. You know, I wanted to enjoy my weekend and have a good weekend, and it just went into Monday and Tuesday and Wednesday, and that's how they can picture their first real pattern of addiction starting for them. Spending a lot of time to get, use, or recover from use. We're going to talk about this later on in the presentation, but time getting sucked up into the addiction is most definitely a huge criteria. Cravings, inability to manage commitments due to drug use, continuing use even when it causes problems in relationships, giving up important activities because of use. So hobbies, enjoyments, continuing to use even when it puts you in danger. This is the criteria that we see where our individuals are now putting themselves in high risk situations. Continuing to use even when physical or psychological problems may be made worse by use. So our mental health is decreasing, our self-care is decreasing. Fewer than 2 of these symptoms, there's no disorder, but 2 to 3, it's a mild disorder, 4 to 5, a moderate, and then of course 6 or more, that is when we get into our severe disorders. We do have a second video here in the first half. This is going to go over specifically how addiction affects the brain, going into the different chemicals, how addiction completely rewires our brain, and how our brains are already set up to respond to an addiction. So I'm going to go ahead and let our wonderful hosts kind of take over from there and get that video set up. Perfect. And I'm going to go ahead and mute myself. Thank y'all. Thank you so much. So pretty impactful video to see how substances really affect the chemistry in our brain, how it affects the dopamine in our brain. One of the comments that I get from individuals in recovery, especially in early recovery, because they are so used to that amount of dopamine, what we refer to as a dopamine dump, when they start going down and start, trying to find pleasure and joy in everyday activities that would bring you or I that correct amount of dopamine, that they kind of convince themselves that this isn't enough for me. So it's really, really important to share this information with our individuals going through treatment, because it does take time for their brains to adjust. It does take time for them to begin enjoying that normal level of dopamine. It is going to take about 6 months to possibly a year. It depends on the substance that that individual was using, and it depends on the frequency at which they were using that substance. So this is important information for our individuals to be aware of. And being aware of this information really helps our target population, to be successful. It increases education amongst family and loved ones. This helps our family members and loved ones of our individuals going through addiction to understand what it is and how it is not a choice. It is a disease. It does impact that that instinctual primal brain that's located in our midbrain. It increases self-awareness, which will help our individuals to process thoughts and feelings of guilt, shame, worthlessness, inadequacy. And that helps to really, really start that process of talking and opening up about it. It increases motivation for change. It allows our individuals to see hope that, okay, this is the science behind it. This is showing me that I can do this. It increases a desire for evidence-based treatment. I want to learn more. If this is what's actually going on in my brain, I want to continue to learn what I can do to help myself. And it assists in furthering autonomy and allowing our individuals to really advocate for themselves. It gives them that voice, it gives them that understanding of their disorder or their addiction, and it gives them that power that they can take hold and take control. Understanding the brain makeup and biology is definitely important, but it's not the only factors to be considered with addiction. So we definitely need to take a really, really strong look at environmental risk factors, and they need to be identified and addressed to ensure a safe and effective healing and recovery. So we definitely want to look at these. So individually, as an individual that we're treating, we need to look at physical health, mental health, social and emotional learning skills, any trauma or resiliency that needs to be addressed. But these can be incredible factors as to an addiction forming or getting stronger. With interpersonal, looking at their social interactions with people around them, their family history of addiction, their family relationships, learned behavior from loved ones, access to support. Within their community, this is also incredibly important. We want to look at definitely the access to harm reduction programming. A lot of communities that we serve may not have a lot of different options for health services, for harm reduction programming, for any kind of treatment programming. So we need to look at that as a factor, and we need to look at how to further intervene. And then societally, so we definitely need to look at the stigma that is surrounding addiction and substance use and mental health, and be aware that in order to successfully reach sobriety and recovery, these are things that have to be talked about. They have to be listened to, and kind of working with our individuals where they are with that stigma, whether that stigma is towards themselves or others, and also passing legislation and policy that helps eliminate that stigma. The impacts of the justice involvement in economic and social advancement within different communities in the society around us. Health insurance coverage for mental health and substance use treatment. A lot of the individuals that we serve, their plans or health coverage may not even look at mental health or substance use as something that they factor in. So a lot of people don't seek treatment. So we need to have options available for them, and the economic well-being and housing stability, of course, as well. Right. So looking at substance use and mental health. So with understanding how substance use and mental health definitely go together, we get a lot of co-occurring disorders. And more often than not, if an individual has a substance use disorder, they are going to have a mental health disorder that needs to be addressed while treating the substance use disorder as well. So we're going to start with what are those most common co-occurring disorders. We have depression, anxiety, bipolar disorder, post-traumatic stress disorder or trauma, schizophrenia, and personality disorders. It's important to note that current estimates suggest that 37.9% of all people with a substance use disorder have a co-occurring and mental illness. Those are just the ones that are documented and diagnosed. We definitely see a lot more of individuals coming through our door that are both diagnosed with mental health and substance use. Research from government agencies highly recommends a dual diagnosis care for these individuals, as it delivers a much better treatment outcomes and makes it more likely for these people to complete treatment. It also makes it more likely for these individuals to continue the maintenance of their recovery. So it's very, very important that we treat both disorders co-occurringly. We can't just treat and look for recovery options for a substance use disorder without simultaneously going through and addressing trauma, addressing depression, addressing anxiety. Okay. So we definitely get this question a lot. I do a support education group for families of the individuals that I serve, and one of the most common questions is, okay, my loved one is there for addiction treatment. So why are they taking medications for depression? Why are we addressing anxiety? Why are they not getting the substance use treatment? Well, they are, because co-occurring disorders are incredibly common, and we need to understand why in order to offer our family members, our loved ones, and our individuals that we serve, why they happen so often together. So we're going to take a little look at that. Of course, the reasons why substance use disorder, there is no specific reason why they occur together, but these are three of the possible explanations that we definitely see correlating to this. So our possible reason number one would be that behavior modification and operant conditioning. When someone has a mental disorder, it increases the vulnerability to substance use disorders. Individuals who have trauma or who have negative emotions that they face on a daily basis, they receive that negative reinforcement when they sit down and take a drink or they engage in substance use, because they're, for at least a short period of time, they're losing those negative thoughts, even if only temporarily. And same with positive reinforcement. I take a drink at the end of a long work week, I feel relaxed, so I'm gaining that positive reinforcement. The possible reason number two would definitely be vulnerability, biology. Substances can lead to mental health symptoms. So substance use disorders definitely increase a vulnerability for mental health disorders. Current substances, of course, can trigger mental health disorders. We see this a lot with methamphetamine, amphetamine, heroin, even marijuana use. Leads to significant mental health symptoms such as psychosis, depression, and increases high-risk situations. So with substance use definitely comes high-risk environments, high-risk people. And when we subject ourselves to high-risk environments, we subject ourselves to the possibility of trauma. And we definitely need to make that awareness aware to our clients that when we put ourselves in these dangerous situations, dangerous things can happen. So we wouldn't want to put ourselves in a situation where trauma can occur. So we definitely need to have that on the forefront and remember that. And then, of course, possible reason number three, both substance use disorders and mental disorders could be caused by shared overlapping factors. Genetics, learned maladaptive behaviors, what was taught to you and what was common within your home or household growing up, and of course, exposure to traumatic or stressful life experiences. When we go into addiction or substance use treatment, like I said, identifying those mental health needs is incredibly important. And where we want to definitely identify and look for those behavioral health needs, of course, we do this through our assessments, our psychosocial, our ASAMs, everything that we do to make sure that we address every single part of the client's life. But just in broad terms, we definitely need to look at behavioral health and emotion. So what is their stress level? What do their social interactions look like? Do they have support in their world? Do they have a good connection of friends? Non-severe conditions. So what does their depression and anxiety levels look like? And then, of course, severe mental illnesses that need to be addressed that have already been diagnosed in the past. Are you diagnosed with bipolar disorder, schizophrenia, or severe depression or anxiety? We need to look at the extent of their drug and substance use, not only the substance that they use, but the frequency in which they use it. The patterns in which they use it are definitely important. The age that they started using, all of these things factor into assessing those mental health needs and individualizing their treatment. And then, of course, critical situations that need to be handled and addressed first and foremost to establish safety for this individual, any suicide or violence within that client's current or past. Okay. And that brings us to about the halfway point of our presentation. Does anybody have any pertinent questions that they would like to ask at this time? And of course, we want to definitely utilize that chat feature if you do. Give y'all a couple of moments to type in any questions. What is an ASAM, or what it was that you mentioned regarding treatment? So an ASAM is just a specific assessment that we do specifically within our facility. It does sorry, y'all. It goes over the specific dimensions that are important to make sure that we go over for substance use and mental health treatment. The dimensions that it focuses on, the first dimension is any withdrawal symptom, any post-acute withdrawal symptom that needs to be addressed so that we can verify if you need detox, inpatient or outpatient level of care. The second dimension is biological conditions, any medical conditions that we need to be aware of, anything that might be pertinent to your substance use or just pertinent to your overall health. The third dimension is mental health and behavioral health. So any mental health diagnoses, any significant symptoms that stand out to you that need to be addressed. The fourth dimension is their motivation. So what stage of change are they currently in? How do we need to address or encourage further motivation? The fifth dimension is their relapse potential. So what is the continued problem potential? How are your cravings doing? How do you view relapse in the future? What do we need to address specifically to your cravings and your urges? And then the sixth and final one is the recovery environment. So what does the support look like in your life? What does your environment look like? Are there drugs or alcohol within your living environment? Are you currently residing in the supportive housing? Do you currently have people around you that are there to support you? Are you involved in any community groups like AA, NA, or even Codependency Anonymous or Emotions Anonymous, anything that might be helpful? Yes, absolutely. Thank you. Determines the level of care that you are going to be at, and also helps continue to authorize you for insurance purposes, and continues to help us as a treatment team understand what area or dimension we need to continue to focus on. So very good question. Any other questions? Get paid. Absolutely. So that we can definitely continue to keep our lights on so that we can continue to help our clients and be there for them. Absolutely. Can you repeat the amount of time it takes to return to regular dopamine levels? You mentioned 6 months to a year. Video mentioned 2 years, the difference. So 6 months to a year is going to be for less significant drugs or less significant substances. A lot of the people that I provide services to are definitely within the their drug of choice being marijuana or alcohol, and then of course methamphetamine. With methamphetamine and significant opioids like heroin, fentanyl, those do definitely can take up to 2 years. And for some substances, there are definitely some dopamine levels or chemical balances that may never return to normal. And that's something that we definitely don't want to happen. So we definitely work on all of the different types of therapy and medication regimens that we can help this individual with, so we don't get to that point. Have y'all heard of PAWS, post-acute withdrawal syndrome? Oh, yes. I've seen addiction centers mention it, but does it have any studies, or is it sort of an explanation of a common process seen in a people's journey towards sobriety? So yes, there's a lot of research out there for PAWS, and that does stand for post-acute withdrawal syndrome or symptoms. And there's a lot of research about it, and we do utilize it to educate our individuals that, as you're going, even though you're not in detox at that moment anymore, or you're not going through those significant initial withdrawal symptoms, you may still have post-acute withdrawal symptoms such as depression, anxiety, or trouble sleeping, or nightmares. So it's definitely important that we talk about that with our individuals with their specific drug of choice. Doesn't that depend on the severity of use, drug of choice, etc.? Absolutely. Absolutely. Post-acute withdrawal is definitely very unique to the specific substance, severity, all of that. What is your opinion on long-term MAT, medication-assisted treatment? So MAT is definitely important. I definitely encourage my clients and individuals to be mindful that medication-assisted treatment is not a resolution. It's a type of treatment, but it is not meant to be used forever. I really, really don't think that it is. A lot of people utilize that, I believe, as a way to cope, and it is not a coping strategy. It is a form of treatment. But the overall goal with medication-assisted treatment is to get you to a point where that is no longer needed. But I think MAT is extremely important, and for us who have never been through withdrawals, watching somebody go through withdrawals is one of the most painful things to watch in your life, and I can't even imagine what they go through. And MAT is incredibly needed and important. I just don't think that it needs to be forever, if that makes sense. Regarding the question on length of recovery and dopamine levels, I guess I'm not understanding what that question is saying. Let's see. Yeah, absolutely. Medication-assisted treatment is not a magic pill, of course, but with counseling, it can be extremely helpful. Absolutely. It is, and there's another comment. It is unfortunate that there have been many individuals on medication-assisted treatment for years. It's quite unfortunate, but yeah, it's definitely needs to be something that an individual is receiving with other treatment like therapy and different types of coping skills, supportive groups. It's not something that needs to be done just by itself. It needs other supportive factors. Oh, no problem. No problem for the confusion. Dopamine levels usually return to normal around 90 to 180 days after moderate use. Absolutely. Severe use could take longer. Yeah, and another individual put many addicts just switch drugs if allowed. Absolutely. That's what we would refer to as cross addiction. And that's why it's important to definitely one of the groups that we teach, especially within the outpatient realm, because they're getting ready to, okay, I've addressed detox, I've addressed inpatient, but now I'm getting ready to go out and be a part of society again. But so now I'm not going to use meth or heroin anymore. I can just drink socially. So we do have a lot of different groups that address cross addiction. And actually, when it comes to your midbrain, your primal brain, where your addictive personality or your addictive traits are located, your brain does not know the difference. When it has a euphoria, and that addiction is already established within your brain, no matter if it's heroin or alcohol, that euphoria is going to trigger that addiction again. So it's very important that we limit and discuss with our individuals that cross addiction is not something that we want to be involved in. If it alters the brain, no, we don't need to do it. Is fentanyl something used to enhance a drug, or is it purely a malicious addiction that producers use? It seems incredibly dangerous that it seems it must be kind of malicious intent or bad will behind it. I am not sure with that one if that is the intent behind it. I haven't read any research about that. Is addicts the proper term to use? Absolutely. As the daughter of an addict and as the treatment team of addicts, they refer to themselves as addicts. That's something that's actually a really powerful statement for them to label themselves, that I am an addict. This is what I have to do to have control of my life. So absolutely. So the solution is forever abstinence. I would say that's the goal. The solution is to continue to evolve as a human being, to find other areas of enjoyment in your life, to create new patterns, to create new habits in your world. And we're going to talk a little bit about that in the treatment and recovery part of the presentation. But ultimately, yes, the overall solution is forever abstinence, but the goal that we are really, really focused on is how can we improve our life without mind-altering substances. Okay. Well, I think we've reached the end of questions there. Rebecca, it just turned 10 o'clock, well, Central Time, 10 o'clock, 11 o'clock Eastern Time. I think that it would be okay to take a 5-minute break real quick, and we can come back at 10:05 or 11:05.
Excellent. I will go ahead and put 11:05 in the chat for everyone. That is when we will meet back.
All right, y'all enjoy your break. I'll see y'all soon.
Hey everyone, we are back from our break and I'm going to turn the presentation back over to you, Emily.
All righty. Thank you so much, Rebecca. Thank you all for all of your questions. I do really appreciate those. And we will get started back. So this is my favorite part of the presentation, the treatment and recovery, the most important pieces. So we've gained a lot of info on identifying substance use disorders and mental health disorders and different needs that we need to be addressed while in treatment. So let's discuss that treatment and establishing recovery in these individuals' lives. So the first and foremost piece that is so important when our individuals come into treatment is establishing safety. Safety is described as the first stage of healing in substance use treatment. We've got to make sure that they're safe. We've got to make sure that they feel comfortable. And the first and foremost piece of that is definitely eliminating the presence of any substances, any high-risk environments, and any high-risk people and behavior. That's why the presence in treatment is so important. It's not only receiving those services, it's also that separation from the current life that the individual was living. And definitely what is really important and why I love the facility that I work for is because we have a supportive housing feature within our outpatient. So we have a sober living hotel that our clients get to stay at. So they are held accountable. Drug tests are given regularly. They do have to have passes to be able to leave the premises, and they are transported to the outpatient facility on a daily basis to receive that treatment and education, group therapy, individual therapy, medication management, all of those wonderful things. So that presence in treatment and establishing a separation is the first and foremost piece. The next, we definitely want to increase the level of support through a multidisciplinary treatment team to address all concerns. This is going to include our therapy, our medications, our group therapy, any resources, advocacy, and of course, especially within the level of care that I work in, beginning that discharge planning and aftercare planning as to what that is going to look like. How can we prepare our individuals to remain safe after treatment? And then next, we want to increase the presence of community through engagement and support of their peers. We want to encourage our individuals to help find similarities between them and their peers. That helps increase their knowledge and understanding of addiction, of recovery, of their mental health. When they find similarities within their peers, it really helps them to feel comfortable. It helps them to feel at ease that, okay, I'm in the right place. I see other people engaging or suffering from the same things that I am, and I feel that I'm in the right place. We definitely also want to establish time between the last use of the substances to create the opportunity for intervention. So we may deal with relapses in treatment. That is something that does happen, especially within the outpatient level of care. Some of our clients live in the community in Arlington. And I did see a question come through, where is that located? My facility is located in Arlington, Texas, which is between Fort Worth and Dallas, Texas. So while in treatment, relapses do occur, and every relapse definitely needs to be fully assessed and intervened within, that individual's treatment plan, making sure that that intervention is definitely individualized. We definitely want to identify all needs that may be contributing to substance use or maladaptive behavior. So this may be physical, what's going on with their medical health or their physical health, what's going on with their emotional health, mental health, and of course, any other stressors in their life, financial, housing, family relationships. So we want to be sure that we're addressing all of those areas that we need to establish safety in. And then we want to create that image of hope and begin intervening with the appropriate level of care. We want to create that safe space. We want to begin that process of validation and understanding, and of course, establish a space where there is no judgment. We want to eliminate judgment altogether. We want our individuals to feel safe to open up and to really, really get to the nitty-gritty of what's going on in their world and how can we best intervene to help them heal. That is the goal. Safety leads to healing. So that leads us to our levels of care. So once we've established that safety, we're going through the assessment process. We definitely need to place our clients in the most appropriate level of care. So of course, I'm sure all of y'all are definitely familiar with this, but if it does do us well to be, specific with these levels of care. We have detox. Um, that would be our 24-hour medical care and physician supervised. This is definitely a dangerous period within recovery for individuals. So the medical involvement is definitely high. This might be where they are receiving titrated medications to help with withdrawals. We definitely want to focus on stabilizing the individuals. Then we have residential and inpatient. This is where our clients live on site. They are, meaning they have 24-hour clinical and medical supervision or care. Clinical intervention here increases and creates the goals for change. Days are scheduled with activities, therapy, and medical care, and leaving minimal free time. We want to completely try to get away from the free time. We want to really, really start engaging these individuals and create that treatment plan that we're going to continue to follow. Then we have the partial hospitalization programs and the intensive outpatient programs. So those usually run together and they're kind of mixed together. So PHP individuals, they receive 20 or more hours per week of that and are designed for complex substance use disorders and co-occurring disorders that do not require 24-hour care. Some PHP individuals, like I said, live in the community. Some of them are within our supportive housing, but it's definitely important to work with that individual and see what is best for them. If the household in the community is not a supportive environment, we may need to look at supportive housing. And then IOP, so that intensive outpatient individual, they start programming at about 9 to 15 hours a week and begin focusing really, really intensely on their aftercare plan. So yes, we're still receiving treatment, but we really need to get together what is it going to look like when there is no more treatment. And then, of course, outpatient. So this is that aftercare plan. This is where individuals begin engaging in med management or outside therapy. Individuals also begin engaging in community support such as Smart Recovery, AA, NA, CA, and a lot of my mental health clients, I get them connected to Codependency Anonymous, Emotions Anonymous, or different support groups that address specific disorders. There's bipolar support groups, there is borderline personality support groups. There's a lot of different support groups that also address mental health. So we want to make sure within those areas that our client needs to establish safety, we want to be sure that all areas are being addressed. All right, so our treatment team. So effective treatment addresses all of the individual's needs, not just their drug use. So we need a treatment team to do that. We need our medical doctors, our nurses, and our addiction counselors. Our addiction counselors, more often or not, are therapists with an LPC license or a social worker with an LMSW or LCSW. And then, of course, our chemical dependency counselors, our LCDCs. And then we have our psychiatrists or our psych nurse practitioners to assist us with med management and psych evals and make sure that our clients are remaining adjusted on medications. We have our case managers and our intake coordinators. They help us with our resources, help us design an aftercare plan. But specifically at my facility, therapists do a lot of that as well. We're a really, really good facility when it comes to interlocking those responsibilities and making sure that the client is taken care of all the way around. But our case managers definitely help with those resources. Addiction recovery mentors and peer specialists and advocates, those are our people that help our clients get connected to treatment or get connected to community resources and help our clients while they're in treatment and to feel comfortable. And then, of course, treatment advocates and mental health techs. Oh my gosh, do they do so much work. And I'm so glad that I had the opportunity to start off in this field as a mental health technician, because I really, really gained respect for our treatment advocates and mental health techs. They do a lot. They are with the clients 24/7. They are the first and foremost, the people that the clients come to for any issues. Our mental health techs are awesome. So if you've ever been a mental health tech or a treatment advocate before, or you are one now, kudos to you because you work hard. Alrighty, so establishing stability, the best way that we can start establishing stability, of course, with therapy and processing, but with that medication management. Medications are often an important part of treatment, especially when combined with behavioral therapies, which we will get into shortly after this slide. So we did talk a little bit already about medication-assisted treatment, but the different meds that are given with medication-assisted treatment are Suboxone, which helps with opioid withdrawals, naltrexone, which helps with alcohol withdrawals, as well as Vivitrol, which also helps with alcohol withdrawals. Vivitrol is actually a shot that can be given on a monthly basis. One of the things that we definitely run into is that insurance is really, really finicky to cover Vivitrol. So looking for different resources to help individuals receive that if they need to is definitely helpful. Oh, FATA covers it. Well, wonderful. That's a wonderful thing. Love it. SSRIs, so our selective serotonin reuptake inhibitors. These are magic. They are definitely helpful, especially in early recovery and with mental health, because like I said, in early recovery, we are experiencing a lot of depression. We no longer have that dopamine dump that we are used to. We are trying to get regulated with our chemical imbalances and trying to deal with that normal level of dopamine and endorphins in our brain. So SSRIs are a really, really good resource when it comes to helping our clients to just feel comfortable in control of their emotions and just all the way around feeling good. So as some examples of SSRIs would be Zoloft, Prozac, Lexapro, but there are a million others on the market. And of course, our psych nurse practitioners and our psychiatrists do a wonderful job of helping our individuals get adjusted on those and picking the correct one. We have our mood stabilizers. Our mood stabilizers can be helpful for our individuals who are diagnosed with bipolar disorder or sometimes even our personality disorders, but also with depression and any kind of mood disturbances too. Sorry. So Tegretol, Depakote, and Lamictal are 3 really, really common ones, but there are also a lot of other ones. And then we have our antipsychotics. So our antipsychotics are definitely utilized a lot in mental health and addiction treatment. A lot of people don't think that addiction treatment requires antipsychotics, but we definitely do. And some of the most common antipsychotics are Zyprexa, Risperidone, Abilify, and those just kind of assist with definitely mood disturbances as well as anything that may come with a mental health diagnosis like schizophrenia or schizoaffective disorder, or another unspecified psychosis disorder. And then, of course, non-habit forming anti-anxiety meds. So we at our facility here in Arlington, Greenhouse Outpatient, we do not prescribe any habit forming anti-anxiety medications, but we do want to make sure that anxiety is being addressed. So some of the ones that we prescribe are hydroxyzine, propranolol. We also prescribe clonidine, but we do want to stay on top of those and make sure that our clients are using them as prescribed. And I did stick Prazosin in there because I did want to tell y'all a little bit about Prazosin. Prazosin is something that was new to me, learning about it maybe about 3-ish or 4-ish years ago. But Prazosin is a very, very awesome medication that has helped trauma and PTSD individuals with nightmares. So Prazosin has been a really, really good med with people who are experiencing severe night terrors or nightmares. So I just wanted to put that on there to definitely notify y'all of, because it's been getting really, really good results. But those are our medications. Oops, I'm sorry, I skipped one. So understanding and coping. So we definitely want to talk about our different therapies and methods of therapy. So treatment should address other possible mental disorders. Counseling and other behavioral therapies are the most common forms of treatment. So of course, that one that we always hear are CBT and our DBT, cognitive behavioral therapy and dialectical behavioral therapy. So changing patterns of thinking and core beliefs, that's definitely cognitive behavioral thinking. We want to specifically increase positive thoughts to improve emotional and behavioral outcomes. When we are aware of our thinking patterns, we can we can definitely help increase positive emotions and behavioral outcomes. So CBT is such a lifesaver and definitely needs to be applied in addiction therapy. Dialectical behavioral therapy is also extremely helpful with addiction and substance use and mental health treatment. Dialectical behavioral therapy is very, very good for our individuals with bipolar disorder and any personality disorder, specifically borderline personality disorder. Somebody just said that right there. Yes, you got it. Borderline personality disorder is definitely treated very well with DBT. DBT focuses on different skills. I love DBT: emotional regulation, radical acceptance, coping and helping calm down urges. DBT is an extremely amazing skill, and we have CBT and DBT specific groups that we teach to our individuals. Definitely love those. The next important one is definitely family therapy. Especially with addiction and mental health, we want to get the family involved. We want to help our clients if they need to, and we want to help the family members if they need to keep the individual safe in recovery. We want to start setting those boundaries and expectations. Okay, so Miss Sally Sue is going to be going home after treatment, but what are those expectations that if she goes home? She needs to be aware of those. She needs to understand what is expected of her. Is she going to have to be going to meetings every week? Is she going to have to stay on top of her therapy and psychiatry appointments? Family therapy is incredibly important, and I encourage every individual in treatment to have a family therapy session prior to leaving treatment, because those expectations are important to set up. And then, of course, just creating those areas of needed support. So allowing our individuals within family therapy and giving them that facilitator as the therapist, giving them that facilitation of allowing them to tell their loved ones what they need. I'm going to need you to stay. I'm going to need this type of support. This is what I'm going to respond to. And something else that I definitely encourage my individuals to be honest about in individual therapy: if I was to relapse, what would that look like? So telling their loved ones, if I was on the verge of relapse or I had relapse, this is what it's going to look like. I'm going to start lying. I'm going to start not going to appointments. So letting our family members be involved with that so that they can fully understand how to help their loved one. And then, of course, trauma informed, definitely beginning that healing process, addressing any effects from the past, and definitely building up the individual's resilience. I'm so sorry, excuse me. Solution focused. So we definitely want to, from the beginning, start identifying goals to work towards, and definitely increasing that self-awareness and understanding. And then this is my favorite, behavior modification, changing any problematic behaviors, becoming aware of any problematic behaviors, becoming aware of how these problematic behaviors started to create patterns within this individual's life, and then gaining new tools and skills to improve outcomes for that individual. Now, these techniques, they are not specifically just for therapists. I mean, all treatment involved parties can utilize these tools and these different types of therapy to engage with the individual and to help increase motivation and increase positive outcomes. All right, and of course, we talked a little bit about substance use education early on, but definitely, as clients are going through recovery, helping them understand addiction is extremely pertinent. We want to further increase the individual's knowledge of substance use and how it affects the different areas of their lives. So understanding the effects of the brain and body are a must, but we definitely don't want to stop there. We need to address other areas, including how it affects their relationships, how it affects their mental health, how it affects society and communities. So the more education that we can show our clients as to how substance use affects not only them, but the communities around them, their relationships, their interpersonal, social interactions, we want to offer them that education. So I thought it would be fun to put a little bit of trivia in here for y'all to kind of just get us through this last little part of the of the presentation. So I want to test y'all's knowledge of substance and drug facts. So please utilize the chat when I put up these questions, but here is our first question. So the question is, what is this substance? So this specific drug impacts hormonal balances in an individual's endocrine system. Heavy use of this drug causes loss of hair, fatty tissue to build up in the breasts, and can shrink the testicles in men. Heavy use of this drug causes hormone and menstrual problems, loss of female features of the body, and decreases the ability to get pregnant for women. So what do y'all think this substance is? And I'll give y'all a second to kind of answer in the chat. I'm seeing a lot of answers for steroids. A lot of steroids in there. I see one for alcohol, steroids, testosterone, steroids, alcohol, steroids, meth, steroids. Okay, y'all ready for the answer? So this substance is actually alcohol. Alcohol, when used in heavy patterns and frequencies, alcohol completely rewires your endocrine system. So women who are heavy drinkers of alcohol, they start losing their female features of their bodies. They start having issues getting pregnant with their menstrual cycle. For men, it's the same thing. It starts messing with their testosterone. They start losing male features of their bodies, building tissue up in the breasts, shrinking of the testicles, and definitely decreases sperm count. So alcohol will, within heavy doses and heavy patterns, are going to completely rewire your endocrine system, lowering estrogen in women and lowering testosterone in men. And yes, someone put, I assume steroids as well. Yes, steroids as well, of course. The next question. So what substance is this? Use of this substance damages brain cells responsible for memory, judgment, and decision-making, and can cause serious mental problems such as depression, anxiety, psychosis, suicidal, and violent behaviors. So basically this question is saying that this drug completely rewires a person's brain. What drug do y'all think that is? I'm seeing marijuana. Any illicit substance? Yes, absolutely. But this one specifically rewires the brain. I'm seeing amphetamines, methamphetamines, alcohol again, hallucinogens, cocaine, benzodiazepines, amphetamine, heroin. So for this specific question, it is methamphetamines and amphetamines. So when methamphetamines and amphetamines are taken, they completely rewire the chemical compound of our brain. Alcohol will definitely, within heavy use, shrink the outer layer of our brain and decrease brain function. Crack cocaine and heroin do the same thing, but methamphetamine and amphetamines are going to create a different brain chemistry, and that's how a lot of mental health and drug-induced disorders are created. I have a therapist that works with me who's in 15 years of recovery, and he told the clients and myself all about just the methamphetamine that is being sold on the streets today. You can use it once and completely go into psychosis. It's important that we understand how strong and how severe the methamphetamine reactions are when used. But absolutely, all substances are not good for your brain whatsoever. And then I just have one last question. How much? So this is a question on a money amount. So the estimated cost of drug abuse annually in the United States, including both legal and illegal drugs, alcohol, and tobacco, is what? This is including healthcare, treatment, incarceration, court, criminal, and purchase fees, plus much, much more that I couldn't think of to write down. But how much on an annual basis for the United States of America does drug abuse annually cost us? I'm seeing 3 trillion, 100 billion, over 500 billion, 10 billion, 1.3 million, 1-ish billion, 15 billion, 10, 3 billion, 1 billion, 700 million. So I think y'all are going to be surprised by this answer. So here is our answer. It is more than $740 billion a year, and it's growing. It is out of sight. I'm seeing a lot of wows come through the chat. Wow, indeed. Yeah, substance use, when it comes on a full level within our incarceration system, our treatment system, rehabilitation system, tickets, court costs, all $740 billion. Isn't that crazy? I'm seeing all y'all's reactions in the chat. I love it. Yeah, I love that. I love that y'all are really surprised by this number because it gives that sense of awareness as to where we are with drug addiction in our country. So that is that question. So thank y'all for playing and participating in those questions. I really appreciate that. We'll go ahead and keep going. So this is that last stretch of our presentation, but we definitely want to continue to seek recovery and recovery capital. Recovery capital is actually a new term to me, and it might be to some of y'all too, but recovery capital is conceptually linked to natural recovery, solution-focused therapy, strength-based case management, recovery management, resilience and protective factors, and the ideas of hardiness, wellness, and global health. So we do want to talk a little bit about recovery capital because this is what's going to help our clients stay in recovery. So the different types of recovery capital, we have personal recovery capital. This includes an individual's physical and human capital. It's available resource to fulfill a person's basic needs like their health care, their financial resources, clothing, food, safe and habitable shelter, and transportation. Human capital relates to a person's abilities and skills and the ability to navigate challenging situations and achieve goals, interpersonal skills, and a sense of meaning and purpose in life. So we definitely address that in addiction treatment. Our second one is family and societal recovery capital. So these resources relate to intimate relationships with friends and family, relationships with people in recovery, their peers, and supportive partners. It also includes the availability of recovery-related social events. Community recovery capital. This includes attitudes, policies, and resources specifically related to helping individuals resolve substance use disorders. Excuse me. Community resources are vast, and they can include anything from recovery activism and advocacy aimed to reduce stigma, full range of addiction treatment resources, any peer-led support such as mutual aid meetings, recovery support institutions, educational-based recovery support such as recovery high schools and colleges, recovery housing, and recovery ministries and churches, visible and diverse local recovery role models, and resources that sustain recovery and early intervention programs. But then we also have cultural recovery capital. So these resources resonate with the individual's cultural and faith-based beliefs, such as resources for Native Americans or people who are from the following faiths, Christian, Islamic, Jewish. So these are the specific resources that are going to be individualized for the individual's culture and religion, ethnicity, so that we can make their recovery and their journey and healing much more individualized. Alrighty. So building new habits through prevention tools. So we need to help individuals that we serve understand that the biggest resource gained in recovery is time. Time is the biggest resource. When they make the decision that I am going into healing, I am going into recovery, they gain so many hours in a day. time and addiction is spent obtaining substances, using substances, lying and manipulating, engaging in high-risk behaviors, and all of that now is gone. So one of the biggest things that we have to do is we have to fill that time. Because during an addiction, an individual stops engaging in self-care, responsibilities, enjoyments, connection with others. So we've got to fill that. So a lot of different ways that we can help an individual do that is cleaning, doing household chores, calling friends and family more often, being involved with the people around them, practicing mindfulness and meditation, their physical health, exercising, cooking, eating healthy, attending to bills, home maintenance, and other concerns on a scheduled basis, learning a new skill, reading books or listening to podcasts, and discovering new hobbies and interests. So we definitely want to address how their time is going to be spent. So that time now has to be utilized effectively to support recovery, and we have to help individuals create these new habits and create a plan to extend them into their aftercare. So maintenance of sobriety. So we definitely want to increase success after treatment. We have to make sure that these specific areas are taken care of within their aftercare plan. So their housing, are we going back home, or are we trying to find a different type of community, such as sober living or Oxford houses? What is our support going to look like? So recovery groups, family, friends, recovery community. Absolutely. I love the comment that just came through. The opposite of addiction is not sobriety. The opposite of addiction is connection. Absolutely. Mental health services, therapy, medication management. What are the services that we are going to be continued to getting into? Career. So are we taking vocational classes? Are we looking for a new job? Are we continuing our education? Or are we going back to our same old job, or are we looking at something different? What might be beneficial for that specific individual? And then, of course, new sober activities, hobbies, coping skills, self-care. What are we going to help ourselves enjoy in our sobriety and in our healing? Maintenance of recovery, relapse, and safety. So this is our last stretch, y'all. So we definitely need to address motivation. So motivation is something that we definitely deal with, and relapse is often influenced by a lack of motivation. So we need to prepare for it. We need to help individuals understand that relapse does not equal failure, but we need to offer further education to stay safe, and that really, really does translate with how do we keep in mind of our motivation. So we definitely need to be mindful and educate our clients on what loss of motivation looks like: overconfidence, complacency, depression, self-pity, unrealistic expectations, dishonesty, lack of discipline. So with increasing our motivation, we definitely want to recognize celebrating ourselves and rewarding ourselves. We want to work on building up our support network, taking one day at a time, creating structure, building confidence, being honest, even when it's hard to be honest. Keep increasing healthy activities and time spent, and be active in a recovery program. Not everybody's cup of tea is going to be AA or NA. Not everybody's cup of tea is going to be smart recovery. There's so many different options out there. Recovery Dharma. There's also recovery classes that are not specifically support groups. There's recovery yoga. There's recovery meditation. There's so many different areas that we can get involved with in a recovery program. Yes, so this, I do believe I saw a comment come by, Rebecca, but we will be sharing this PowerPoint, to my understanding. This will be available.
Yes, and it's also in the chat for them as well.
Absolutely. Relapse as a part of recovery. We need to prepare for relapse because it does happen. Individuals need to be aware of how to respond to a relapse, especially if they are already out of treatment. We need to be mindful of the risk factors and how to respond to the actual relapse. So different relapse risk factors: exposure to triggers. So we need to be mindful of the environment that we're placing ourselves in, stress and how we're handling stress, interpersonal problems. So conflicts with spouses, children, work coworkers, peer pressure, lack of social support, any pain due to injuries, accidents, or medical issues, low self-efficacy, and positive moods are even a trigger. So what to do right after a relapse? So we need to really, really instill in our clients, this is normal. This is normal. We have validated that it's happened. We can move forward from this. We need to reach out for help. We need to attend a self-help group, call a sponsor, avoid triggers, set healthy boundaries for yourself, engage in self-care, reflect on that relapse, and develop a relapse prevention plan. Right. Sorry, I'm kind of running out of time as we're going through this. Here's our last video. I do want to go over overdose prevention. This is incredible information for our clients to be aware of. I try to teach this within my facility or show this video or go through the process of training how to administer Narcan at least once a month, if not more. It's incredibly important for our individuals in this population to be aware of where they can buy Narcan, how to administer it, and what are the risks in administering it and all that. So we're going to go through this video real quick just to gain that info, and then we'll be moving on. So we are ready, Rebecca. Yes, so naloxone is incredibly important to have on site at any treatment facilities. I see a message in the chat, cloxido. I haven't heard of that before, but it's being used more than Narcan now due to heroin being replaced with fentanyl. Instead of using 2 to 3 Narcan, only 1 cloxido nasal is needed. Huh, very cool. So I'm gonna have to do some further research on that. Thank you for sharing that. One of the few things that I do want to say about opioid overdoses, um, even if a person is not suffering from a specific opioid overdose, but you suspect an overdose, administering Narcan is not going to hurt the person, even if they're not experiencing an opioid overdose. It's best to just be safe and administer it if you suspect an overdose. If the first administer of Narcan does not take or does not work, you can continue to keep administering more doses every 2 to 3 minutes. So it's definitely important to be mindful of. Narcan, naloxone is available at every single pharmacy. They usually keep it behind the counter with the pharmacist, but you can ask for it and it's available to the public. And then our last slide here, ongoing preventative care. So just continuing to help our individuals. We want to continue to further education and knowledge of substance use. There's different trends coming out every single day, it seems like. So definitely keeping our individuals informed, implementing effective community-based prevention programs. So we as providers have that effect to help encourage policy changes and help our communities be more ready for addiction and mental health. Encourage the importance of continuum of care and aftercare. Creating and implementing supportive policy changes that increase healthy communities. Advocating for individuals and their families and help connect them to further resources. And of course, encouraging ongoing services that address all areas of health: physical, mental, psychological, and spiritual. And that wraps up our presentation, but I'm going to go through and show y'all these resources real quick. So I want to be able to allow y'all some time to see these resources. So we have, of course, SAMHSA, we have FATA, of course, National Institute on Alcohol Abuse and Alcoholism, Real Deal on Fentanyl, NEDA, the Opioid Response Network, the Administration for Children and Families. All of these resources are so impactful and giving so many good resources for our individuals. I have another slide of resources right here. So Google's custom map can help individuals find recovery meetings from NAAA. In the Rooms is such a good app, y'all. You make an account to it like Facebook, and our individuals can find online meetings or meetings in their community. It's not just recovery meetings. It's codependency meeting, Emotions Anonymous, meetings for specific mental health disorders. One of the things that I found on there that I really resonate with, because I mentioned that my mother is 16 years in recovery, there is also children's of addicts meetings on there as well. So In the Rooms is such a very good resource. Virtual resources are also available from SAMHSA, LifeRing, Secular Recovery, Addiction Policy Forums, Connections, and Recovery Research Institute. Then I'll slowly go through my references real quick so that everybody can see where my lovely information came from. And we have one more slide of references. So we have probably about 5 minutes because Rebecca does have to wrap us up, but I do want to offer any specific questions that anybody may have. Oh, y'all are very sweet. Thank you. I'm getting comments of very informative webinar. Thank you for this presentation. There are terms I have heard but was not clear about, and the resources are very helpful. Thank y'all. What type of treatments and therapy is available for those who are socially lower functioning adult individuals, such as those, sorry, I keep losing that comment, such as those on the autism spectrum. So there are uh, many facilities out there who they're basically co-occurring facilities. We have a couple in Texas. Ours is actually a co-occurring facility too, but our primary is addiction. So we try to look for individuals who have disorders such as those, for primary mental health and secondary substance use. So their primary mental health needs are being addressed, and they have the staff and with the awareness of how to manage those specific diagnoses, while also creating an individual treatment plan for addiction. So definitely looking into treatment facilities that are co-occurring but with primary mental health. Thank you so much. Very good webinar. Y'all are very sweet. Thank you so much. Trying to look for any more questions. Enjoyed the webinar. Oh, y'all are very sweet. Thank you. Yeah, I'm very, very glad that I did this. Y'all were a fantastic audience. Y'all had amazing questions. Y'all were just so involved and engaged and participated. I really appreciate you guys. Oh, just making sure no more questions. Oh, thank y'all very much. I really appreciate y'all too. Rebecca, do we have anything that we need to end with?
Yes. We need to go through some closing slides and give everybody some closing information here. So I wanted to let everyone know we've included Ms. Clark's contact information on the screen right now so that you may contact her with any further questions. And we wanted to, at FATA, thank you very much for all the work you put into the presentation and all of the information that you shared with everybody today.
Thank you. I really appreciate it. I'm actually going to turn on my video real quick just to say hi to everybody. Thank you very much for just being here, for supporting this presentation, and I really appreciate all of y'all. So thank you very much. Really, really appreciate it. And thank you, FATA, for this opportunity. I really enjoyed it.
Is great, and we appreciate everything you did, and you're getting high remarks in the chat as well, so that's great. And everyone, please hang on for a few more minutes. We have a couple of items of business to note before we conclude today's webinar. Please see the chat panel for an additional link to the evaluation. The evaluation is necessary to take if you want to receive CE credit or statement of credit. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must have provided an accurate Florida Department health license and prefix number when you registered for this webinar. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for today's webinar as what you have set up in your FATA profile, as this is the only way to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The evaluation will close at midnight, Monday, December 12th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 days after the evaluation closes. Thank you all again for participating in today's webinar. We'd like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Thank you so much, Emily, and thank you all. Please hold and we will send you to the evaluation. Thank you all.
Thank you. Appreciate y'all. Y'all have a wonderful day.